Good morning, everybody. Thank you so much for joining us today for Global Neuroscience Grand Rounds. My name is Dr. Jill Farmer, and I'm the director of the Movement Disorder Program with GNI. And I have the pleasure of introducing my friend and colleague, excuse me, for today's talk. Before I do, just a few housekeeping things to go over. This is CME eligible. And if you were able to view the scroll that was on just before we started today's presentation, you can claim CME credits via the EEDS website. You will also get an email, or should be getting an email about how to do that, as well as a reminder after the talk. And as this is a webinar, all participants enter with their cameras off and on mute. So if you do wish to ask a question, which we strongly encourage, because we'll go over that at the end of today's talk, please do so through the Q&A feature at the bottom of your screen. And you can put in questions during the course of the talk. They'll come to us, and then at the end, we'll go through them as they have come in. And with that, I now have the pleasure of introducing Dr. Peter Gliebus. Dr. Peter Gliebus earned his medical degree from the Faculty of Medicine at Vilnius University in Lithuania, where he was born. He completed the Drexel-Honman Neurology Residency Program in 2008 and a 2-year fellowship in behavioral neurology and neuropsychiatry at Northwestern University Feinberg School of Medicine's Cognitive Neurology and Alzheimer's Disease Center. He is currently the director of cognitive behavioral neurology with GNI and is also the academic chair for Drexel Neurology. He has contributed to the AAN Continuum on Cognitive Behavioral Neurology and has edited the book Progressive Cognitive Impairments and Its Neuropathological Correlates. And in 2019, he was named a top doc by Castle Connolly. And with that, take it away.
Dr. Farmer, thank you very much, and good morning, everybody. It is definitely my pleasure to talk today and to talk about the topic that we all see these patients so frequently, but sometimes we're a little bit confused when it comes to diagnostics and even the treatment. And I just want to make sure that I project my screen correctly. Okay. Neat. So here it is. So today, as Dr. Farmer said, I will be talking about normal pressure hydrocephalus and the current understanding of the disease and the diagnostic. The treatment is really not the main focus of this talk, because it actually deserves probably a separate talk. So I do not have any relevant disclosures to report when it comes to this presentation. What will I be talking today? We'll review some history of how did we come to know this disease. We'll review the clinical presentation, how does this disease develop, the mechanism of the development, etiology, as we know, the diagnosis, and just as I said, just mentioning the treatment, which is there is only really one treatment for the disease. So I will start with a historical perspective of this disease. So this disease, the Colombian neurosurgeon Salman Hakim was the one first described this disease in 1964. And he made a profound discovery that he found these patients who had hydrocephalus. And at that time, let's remember that we're really the neurology and neurosurgery where there's this black box where you didn't have the good imaging. You had to use the pneumoencephalograms, et cetera, to diagnose these patients with hydrocephalus. So he found these patients who had hydrocephalus, but they had normal intracranial pressures. He traveled to and he shared his observation with his colleague, Dr. Adams at MGH, and they published this first probably seminal paper when it comes to this condition. It's called the Special Clinical Problem of Symptomatic Hydrocephalus with Normal Cerebrospinal Fluid Pressure. Observations of cerebrospinal fluid hydrodynamics. So they were talking about several cases, but they went into detail to describe 3 cases, which looking back were more likely to be the secondary normal pressure hydrocephalus rather than the idiopathic. But again, this observation opened the door for further evaluation of these patients and really trying to understand why some patients develop this condition. Now, when it comes to epidemiology, the normal pressure hydrocephalus has its highest prevalence in the 7th and 8th decades and is rare in people younger than 60 years. However, young patients ranging from neonates to young adults might develop normal pressure hydrocephalus, but obviously in that case, it's more likely to be a secondary normal pressure hydrocephalus. Now, the prevalence in general population is unknown because some patients may manifest only with gait impairment and without any cognitive deficits or without any urinary problems. A survey of medical records in Olmsted County, it's in Minnesota, established the incidence of MPH as about 1.19 per 100,000 people per year. The Swedish survey, and in Sweden, it's a little bit easy to do these surveys because of the centralized medicine. The prevalence of probably idiopathic normal pressure hydrocephalus was about 0.2% at the age of 70 to 79, but it really raised sharply to 5.9% in patients 80 and above. There are authors who dispute this. They say it's a little bit an overestimate or underestimate, but again, probably numbers are on average are about from 1% to 6% in the population. Clinical presentation. Obviously, everybody, even from the medical students, they do know this classical clinical triad. It's these patients have a gait change, these patients have urinary incontinence, and these patients have cognitive impairment. The gait impairment associated, it is usually if you have this triad or you have just some of the symptoms, it is suggestive of normal pressure hydrocephalus. What is missing in this triad is one of the main components, and that is that these patients have to have ventriculomegaly. So you can't, because gait changes and cognitive impairment is also part of so many other disorders. So especially if the students are listening, it's gait change, urinary incontinence, cognitive impairment, and ventriculomegaly. The patients don't have to have, and frequently don't have all three of these symptoms. Gait change could be frequently the initial symptom presenting with patients with MPH, or sometimes they can present with gait impairment and cognitive impairment simultaneously. The urinary incontinence is more frequently to be the late symptom, and if urinary incontinence is early or the first symptom, and then actually it really raises the question whether the urinary problem is related, it could be related to normal pressure hydrocephalus. And also to remember that this is a slowly progressive disease. So, and if untreated, these patients can present to a fairly pronounced dementia stage, as well as fairly significant akinetic stage. Now, what are the gait abnormalities? So, as I said, it's usually an early sign. It could be a first sign, or it could present with together with a cognitive impairment. And the classical gait change is what we describe as a magnetic gait. So feet are stuck to the ground, and that is fairly typical to this condition. These patients have difficulty initiating gait. They have short shuffling steps. They have wide gait, and I'll show this a little bit later. Their turns are very unstable. They take multiple steps to turn around, what we call en-bloc turning. Now, in these patients, also the posture instability is common, and falls obviously can be frequent as well. Now, the gait abnormality has to be distinguished from weakness. They have the difficulty magnetic walking, or what we call magnetic walk, not because that they are weak. The strength typically is preserved. But what is interesting that these patients usually retain the ability to imitate motor abilities while sitting or lying down. For example, if you ask them while they're sitting or lying, show me how would you walk or ride the bike, they can do that. But when they have to do that while walking during the gait, they cannot do that. And that's why we call this a gait apraxia. It's really not a true apraxia in a true sense, what we call apraxias, but that term was introduced and we use it. here is just, some examples of how it is different comparing to other gaits. So in the middle, you see normal gait, so you see the normal width and normal steps. Parkinsonian gait, it is small steps, it's shuffling, but they're not wide based steps. Now, in the normal pressure hydrocephalus, you see the stance is wider, and the feet are also tend to be more externally rotated. So when you see in many of these patients, you actually start to differentiate just by looking at their gait, whether it is the Impaired type gait or it is Parkinsonian type of gait, gait problem due to other disorders. I have a couple of videos to show, and if you see here that a person stood up and just can't initiate, but also pay attention also because that initiation could be Parkinson's, but pay attention to the external rotated feet and also the wider stance. And it literally, the feet seem to be glued to the floor. And I'll have another one more, I'm sorry. One more video. So again, the person has difficulty standing up, and again, glued to the floor, and the wide stance, walking, and then it all got stuck. Can just made a little stop, and again has absolutely a difficult time initiating. And the wider stance, they're just not lifting their feet. So obviously this is a little bit more severe case because this patient is really disabled because of the normal pressure hydrocephalus. And just again, this is, but it's fairly typical and very, very small steps, wide-based, and the feet are just barely lifting off the floor. Let me see. So that was the gait presentation, the typical gait presentation of normal pressure hydrocephalus. Now, cognitive deficits usually occur simultaneously with the gait problems, sometimes a little bit later, or sometimes some patients can also present before the gait problem, but frequently these are going hand in hand, and then we'll see that it's also based on the anatomy. And we're now talking about the why do we develop these specific syndromes? Is the cognitive networks are so close to the motor networks in our brain, and especially in the frontal and prefrontal areas. But the typical changes in cognition we found in patients, these are the patients might have psychomotor slowing. They have reduced or absent insight into their deficits, so they're not really aware that they have problems. They have this executive syndrome, the frontal cortical subcortical deficits. They might have amnesia. They do have the apathy and bradyphrenia can be prominent. So again, these patients are slow to respond, have this executive syndrome, and they're forgetful. Urinary symptoms. So typically, again, we know that urinary incontinence is a typical symptom of the normal pressure hydrocephalus, but it rarely starts with incontinence. It usually starts with the hyperactivity of that micturition reflex, and it as an urgency, and these people have to just frequently run to the bathroom when they need to go. Now, when the disease progresses and the urgency, and remember that I'll be talking a little bit more about that the continence itself is more controlled from, or the higher with the supratentorial regions, as opposed to the micturition is more the pontine function. So when we start having the frontal problems because of the developing hydrocephalus, that continence reflex starts getting affected and the declaration reflex start getting more active. Now, as disease progresses, people become incontinent, and as disease progresses even more, people become, and I will try to pronounce all the people who speak French, please don't laugh, incontinence sans gêne. It means that it's like with oblivion. These people are incontinent, but they really don't care that they're incontinent. They pass their urine in front of other people, and they have absolutely no shame about it. So, and that tells that this pronounced, profound frontal impairment. Now, your fecal incontinence rarely can be present in a normal pressure hydrocephalus, but that is usually in the advanced stages. And again, it's definitely more rare than urinary incontinence. So what is the etiology? We're all just, it's, as the name implies, it has to be a hydrocephalus, and hydrocephalus, just in general terms, is an increase in volume of CSF within intracranial cavity causing ventricular enlargement. Hydrocephalus can be classified as an obstructive and non-obstructive. Obstructive, the other name is non-communicating, is when there is an obstruction of the CSF flow, usually communication between the ventricles and the subarachnoid space, and non-obstructive when there is no obstruction of the cerebrospinal fluid. Now, frequently, which one is the normal pressure hydrocephalus? It's more, we refer to normal pressure hydrocephalus to the non-obstructive one, but sometimes people also use an MPH term. In the obstructive cases, it's more the semantics. Treatment management is the same, but again, classically, typically, it's a non-obstructive hydrocephalus in the case of NPH. Though when we'll see the etiology, there could be some local obstruction that's going on, and that is especially over the cerebral cortex and over the convexity of the brain, that technically should become at least the focal obstructive. Now, hydrocephalus in NPH develops because of the insufficient absorption of the cerebrospinal fluid through the arachnoid granulation and arachnoid villi of the superior sagittal sinus, or obstruction of the flow around the convexities. And again, that causes the dilation, and we'll be talking a little bit more in going into the physics about the development of this disease. The normal pressure hydrocephalus can be classified into idiopathic and secondary normal pressure hydrocephalus. The secondary normal pressure hydrocephalus usually develops due to subarachnoid space fibrosis, and that we see in the patients who have a history of subarachnoid hemorrhage, meningitis, head injury, or because of the elevated levels of longer lasting, the chronically elevated levels of the CSF protein, for example, in certain oncological diseases. Now, if no history of above is present, then that's when we call it's idiopathic normal pressure hydrocephalus. We can talk about hydrocephalus not touching physics, but I promise there's not a lot of it here. But at least partially, and again, the more we know about this condition, the more we know that it's more than just these physical forces. But at least partially, the development of the hydrocephalus and normal pressure hydrocephalus could be explained by the Pascal's law of hydrodynamics, and that is that the force that is exerted by the CSF on the walls of the ventricle is equal to the product of pressure of the fluid in the area of the wall. So if the force is increasing, the area is increasing. That helps to keep the pressure in check, and hence the normal pressure. Again, this is just a partial explanation, because it's developing this condition is way more than just the simple hydrodynamics. Now, as I said, during the development of this, the idiopathic normal pressure hydrocephalus, I think it's because of the diminished resorption of the cerebrospinal fluid into this superior sagittal sinus, or due to the focal obstruction in the subarachnoid spaces. But anyway, there is a decrease in the CSF resorption. There is that causes increase in the transmantle pressure. Transmantle pressure is a difference. It is a pressure between the intraventricular cavity and the overall the subarachnoid space, or the cerebral convexity, and that leads into ventricular enlargement. Now, there are these hairs in the NPH patient that were noticed, and some other conditions. There are these short-lasting CSF pulsations that were called the B waves that periodically apply pressure to the ventricular walls and have this water hammer effect that enlarges the ventricles. Now, the damage to the tissue in case of hydrocephalus is mainly done through these mechanisms. So by mechanical changes, such as combination of tissue distortion, CSF interstitial fluid stasis, and also impaired cerebral perfusion due to increased pressure on the tissue. And actually, this impaired cerebral perfusion, we're becoming more and more aware that probably plays a significant role in the development of these of the symptoms, and then improvement in the cerebral perfusion in the improvement in symptoms after the treatment was initiated. So why do we develop the MPH? What is the MPH pathogenesis? So we can divide all the theories about the development of the disease into, the ones that are talking about the structural changes, the ones that are talking about cerebral blood flow changes, and the ones that are talking about cerebrospinal fluid flow changes. So what are those structural changes? Tissue distortion, and tissue distortion occurs due to the increased intraventricular pressure. And initially, the pressure is the highest in the paraventricular regions, and that distends white matter tracts, and also distends and affects the blood vessels. And that slowly also causes the loss of the brain elasticity, and that, also the loss of the compliance, and, these pressure fluctuations might be more prominent. Now, there is also increase in interstitial fluid pressure. So when there is this increase in intraventricular pressure, that disrupts the balance between the normal hydrostatic and osmotic pressures. And there's also accumulation of the toxic metabolites in the interstitial fluid that on their own affect the metabolism of the cerebral tissue, the normal flow of the information through the tracts, normal homeostasis. So again, it's not only the pressure, but that pressure causes the mechanical distortions, also the drain, and also the drainage of the toxic metabolites from the interstitial fluid. Cerebral blood flow changes, and we're becoming more and more aware that those are play fairly significant change. Again, the force that exerts on the ventricles is transmitted centrifugally, towards the cortex, compressing the brain and elevating the transmantle pressure. And again, as I said, transmantle pressure, difference between the ventricular pressure and the pressure over cerebral convexity. And the result is a global decrease in the cerebral perfusion because of elevation of this pressure. Now, multiple cerebral perfusion studies have shown a consistent increase in cerebral blood flow, and I was mainly in the frontal cortex, paraventricular, white matter, basal ganglia, and thalami. Now, enhancement of cerebral perfusion also was demonstrated in people who were treated, who had a surgical, the CSF shunt treatment. There was an improvement in cerebral blood flow, and that's just one of the studies demonstrating. So there's a perfusion scans, and you see the middle one is the pre-treatment, and the bottom one is post-treatment, and you see that the perfusion actually is fairly spotty in different regions, and then how the perfusion increases after the treatment. So again, and obviously it cannot be this type of the perfusion fluctuation, this type of the perfusion suppression cannot really be asymptomatic, and that contributes on its own, without that even the mechanical component on its own, to the development of the syndrome. Now, normally, CSF production equals CSF absorption. The flow is from the ventricles to subarachnoid space, and then to the superior sagittal sinus. Are there any CSF, are we aware of any CSF flow changes that contribute to the developing of a disease? And I think even historically, it was one of the first things that was recognized that this disease develops due to the imbalance between the CSF production, circulation, and absorption. Now, another thing, what happens and why, because it's the idiopathic normal pressure hydrocephalus, as I said, it's the, probably the main risk factor is aging. And what happens with aging brain, it also loses the elasticity. Now that elasticity is like almost the prevention even for the intermittent pulsations or increase in intracranial pressure. The brain is elastic, it can absorb it, and then it returns to its prior stage. Now, when the elasticity is lost, obviously, when there is an extension, the buffer mechanism is really not working very well, and that is one of the things why people, I think that the aging is one of the main risk factors in developing the disease. Again, there are these, the abnormal spikes in the CSF pressure, the presence of the B waves, that results in the intermittently raised increased intracranial pressure, and as the older brain with diminished elasticity, that might make the brain more susceptible in developing ventricular megaly. Now let's talk a little bit about the overall anatomy and why and PH presents with these, the gait, the cognition, the urinary symptoms. One thing is it is defined by the anatomy. So let's remember that ventricular megaly. When ventricular megaly develops, obviously mechanically the closest areas to the ventricles, and especially in the frontal horns, those closest tracts are the most susceptible to being affected. And that's where we have these motor tracts and the urinary control tracts. They are in these paraventricular regions in the frontal cortex. So here is just a demonstration of the corticospinal tract. If you remember the homunculus, and the other picture will be a little bit clearer, but the leg innervation comes from about here. That's just, so that these fibers would be going really paraventricular. So when we do have a hydrocephalic change, these fibers are very susceptible. They are very susceptible to the condition. Now this is a little bit better. As here you can see the homunculus, and you can see, if you will, the motor fibers from the legs, they really go right by in the paraventricular regions, and the other body parts are not as affected. Now here you can also see the superior longitudinal fasciculus, which is next to the corticospinal tract, and that also the malfunction in this and other, I have another slide for the cognitive tracts, malfunction in this tract along with other tracts contribute to developing of this executive syndrome, amnestic syndrome, the psychomotor slowing. Now, I do want to point one thing, that probably this does not necessarily answer the full clinical picture, because if you will really look by the book, the effect in the corticospinal tract, when there is a malfunction of corticospinal tract, you do have, it presents usually with weakness, and it's not what we're dealing here with. We're dealing here with the loss of the ability for people to walk, the loss of that program of walking in the brain. And that's where probably it comes in that because of all the pressure changes and the cerebral perfusion changes, we have the perfusion change in the premotor areas as well. And that's where the supplemental motor cortex is. And probably the malfunction of the supplemental motor cortex due to perfusion changes is possibly contributing to that full ataxia, gait apraxia syndrome. Again, this is just to show the corticospinal tract, not going into details, but here you see the normal subject, and here you see somebody with a hydrocephalus, that this tract is definitely very vulnerable to the disease condition, to this condition. Now, here are more tracts, and this, again, you see the number one is a pyramidal tract, and we talked about it, and you see how it really loops around the ventricle, but there are other tracts that are involved. I did mention the superior longitudinal fasciculus is also vulnerable to this condition, and that's why we develop these executive syndromes, but there are other tracts that are affected by the developing of hydrocephalus, developing normal pressure hydrocephalus. One of them in this is a singular fasciculus, and it starts in the singular gyrus, and that is this tract is very important. So let's remember from the anatomy, one thing, it's part of that paved circuit, so it's important in memory formation. A singular tract is also, singular fasciculus is very important in the attention allocation. That's these people might start developing the attentional problems. And also we have the corticostriatal and corticoreticular connections that are affected in this disease. And again, that contributes to the frontal subcortical type of executive impairment. Now, urinary control, when it comes to urinary tracts, it's probably less clear. But anyway, just as a reminder, there are two main reflexes, the micturition reflex and continent reflex. Micturition reflex, it helps us to go to the bathroom. Continent reflex actually holds that back. Now, normal adults can postpone or have some micturition that ensures that urination occurs only when consciously desired and socially appropriate. Not necessarily going to go into detail into this scheme, but overall, this is your micturition reflex. So it's the pontine micturition center is very important, and also the periaqueductal gray that plays a role. And I say, remember, if the reflex is affected, like in a spinal cord injury, then we have the urinary retention. Now, the continence is a little more complicated than the simple micturition reflex. And that does involve many regions, including frontal, prefrontal, and medial frontal regions here. And again, when I was talking about the expansion developing of the hydrocephalus, especially in the enlargement of the frontal ventricles, the connections from all these different parts of the frontal regions, they go periventricularly, and that's why people start having initially urgency and then develop the incontinence. And then as the frontal, if it is left untreated, as a frontal function continues to deteriorate, these people become incontinent, and they don't care that they're incontinent, and they're incontinent at all the inappropriate places. Again, this probably the medial, the anterior cingulate region, the medial prefrontal cortical regions play a significant role in the continence, and it seems like when you extrapolate all the data from the anatomy from the hydrocephalus, and then the connections from this region to the lower brain regions are playing a role in developing of the classical urinary presentation of the disease. This is not going to, this is just to illustrate that's how, all these different tracts, and some of these tracts paraventricularly, and then when we have this mechanical problem, the possible, stasis and toxins, and plus the cerebral perfusion diminished, obviously mechanical problems will affect the tracts that are closest, but then the stasis and cerebral perfusion impairment might affect also the tracts that are not even really that relatively close to the ventricles. So that was a little bit about the anatomy. Now the diagnosis, how do we diagnose the disease, and what are the neuroimaging findings for the normal pressure hydrocephalus, and what are the diagnostic interventions to diagnose this condition? Well, probably one of the most widely spoken is this Evans ratio, and it is defined as the maximum ventricular width, and you measure that in the frontal horns, divided by the largest biparietal distance between the inner tables of the skull. And Evans ratio at least 0.3, so 0.3 or above, it usually indicates the hydrocephalus. And again, in order to have normal pressure hydrocephalus, it's not only clinical presentation, you actually have to have hydrocephalus. Again, just another showing, of the calculation on the Evans ratio. There's also this, what we call the callosal angle, and that's the angle in between the ventricles, and in the normal pressure hydrocephalus, it's usually less than 90, but more than 40. If it is more than 90, then it's considered, could be that the hydrocephalus could be ex vivo due to the atrophy. But again, this is a little bit more obscure finding, but you might hear about this callosal angle. DASH. There is several. It is also considered now the subtype of normal pressure hydrocephalus, and DASH stands for the disproportionately enlarged subarachnoid space hydrocephalus. And the features of that are that there is an enlarged sylvian fissure, but there is a crowding in the high convexity region. And that would, this combination sort of, because, when you see enlarged sylvian fissures, like, oh, is it atrophy? But if it would be atrophy, that sort of also, you can use it as a reference. So maybe it's not atrophy because this is so crowded, I don't see an atrophy. So it could be this arachnoid space hydrocephalus. And that's, as opposed to, some enlargement here. It's not, but some enlargement of the sylvian fissure, but, there is no crowding of this high convexity region. And I think what we see in a normal pressure hydrocephalus is transependimal CSF leak. And that is purely due to the increased hydrostatic pressures. You see the white matter changes. Again, so that clinically, it's easy, to talk about them theoretically, but clinically, sometimes it's a little bit confusing whether it's really, transependimal CSF leak, or are we, dealing here with a paraventricular white matter changes. And sometimes what we can see also these focally dilated cell sites, and it's probably because of the subarachnoid fibrosis, but you can see these, like literally jumps out the cell size. So that sometimes can be also seen in this condition, and more probably likely to be maybe in the secondary just by the mechanism of the development. And again, this is not diagnostic. You already saw this. We're not using, but again, this is just, one of the findings is a diminished perfusion. The brain that does correct when with a treatment. Just remember that the diminished perfusion plays a significant role in the pathogenesis of this disease. Now, there are these international guidelines for imaging normal pressure hydrocephalus. And one thing, you have to have the ventricular enlargement not entirely attributable to cerebral atrophy or congenital enlargement. So again, Evans index should be equal or more than 0.3. There are no macroscopic obstruction of the CSF flow, and at least one of the following supportive features, such as enlargement of the temporal horns of the lateral ventricles that are not entirely attributable to hippocampal atrophy, the callosal closed eye angle more than 40 degrees or greater, evidence of altered brain water content, including paraventricular signal changes on CAT scan and MRI. That is not attributable to microvascular ischemic change or demyelination. I like these. It's like, and how do you know, it's so difficult to differentiate when you're just looking at the scan if you don't have the, you know, other components. And there is an aqueductal or fourth ventricular flow void on seen on MRI. So that was just imaging findings. Now, you know, what are the other diagnostic interventions? So regular LP, probably nobody uses to diagnose it because it's really a low sensitivity. But, you know, that depending on the center, it could be high volume lumbar puncture or external lumbar drainage. High volume lumbar puncture, removal suggested up to 50 milliliters. Sometimes, you know, you have to worry a little bit, especially if you have some brain atrophy of developing arachnoid, subdural, with quantitative. So when you remove one thing, you do some quantitative measures of the cognition and gait prior to removal and then after the removal. Now, it is the only procedure that can temporarily stimulate the effects of the definitive shunt and can predict not only the outcome of surgery, but also the degree of the improvement. And the sensitivity to shunt response reaches up to 70%. And taking into account the low complication rate for high volume LP, many centers actually are opting to use the high volume TAP test rather than external lumbar drainage. Now, external lumbar drainage, a continuous external lumbar drain for 3 to 5 days with a minimum of 150 milliliters of CSF drained daily. There is high sensitivity, probably highest sensitivity in the TAPs, but it does require hospital admission and it is associated with a high complication rate, up to 10% of complications. So 1 in 10 patients might develop meningitis, subdural or nerve root inflammation, or even mechanical damage. So it's really, while sensitivity is higher, the complication rate sometimes it makes you really think whether it's, you know, whether it's that good of the study as a whole. And again, this is just one of the, you know, examples show this external lumbar drain. Now, MPH and Parkinsonism, you know, so it's good, you know, when patients present with a clear clinical picture, but unfortunately, it's not the case, and actually quite frequently. And it was noted that some of the patients with a normal, who present like normal pressure hydrocephalus, they also have these extrapyramidal Parkinsonian symptoms and signs, you know, the rigidity, the tremor, you know, et cetera. And there was one prospective study that was done, and they enrolled 30 patients who had MPH and Parkinsonian symptoms and signs. The DAT scan was abnormal in almost half of them. All these patients underwent spinal tap tests, and the ones that benefited, and the majority of them benefited from the spinal tap test, some of them were treated just with a VP shunt, and some of them treated with a combination of the VP shunt and dopamine supplementation. So the group that were treated with shunt and dopamine supplementation that were superior in their performance and overall their functional recovery. Now, I think, you know, it becomes more of the academic discussion. Do we say that these patients have MPH and Parkinson's disease, or MPH, or at least partially responsive to DOPA Parkinsonism? There is no clear-cut answer, but it is clear that there is a subgroup of patients who have this MPH and who have also the intrinsic nigrostriatal dopaminergic abnormalities. Now, there are also reports of MPH and Alzheimer's disease. So, you know, probably the main take-home message here, that normal pressure hydrocephalus does not protect from having other diseases, and vice versa. Having other diseases does not prevent from developing MPH. In the cognitive world, we're becoming more and more aware. I mean, 50% of dementia cases now we think are mixed cases, like Alzheimer's with vascular Alzheimer's with hippocampal sclerosis, Alzheimer's with Lewy body disease. The same as with MPH. It's probably where we will encounter the patients, and the patients where we like scratching our heads, well, it looks like MPH, but it has non-MPH features, might be just that there are some other diseases that are going there. And then, the question arises, how do you treat them? And you still do the workup for the MPH. And if there is, you see the, reasonable improvement from the TAP, they might have also this normal pressure hydrocephalus. Remember that, again, normal pressure hydrocephalus are the main risk factors aging. It's this, loss of brain elasticity, et cetera, what we were talking about. So aging population might have normal pressure hydrocephalus and other conditions. Now, is there any way for us to predict the response? To one thing, do we have any tests that are sensitive enough to capture the change pre and post? Let's take TAP. And also, are there any tests that could help us to predict the response to shunt? So first, just going to talk a little bit about that. Why do we use the test? We use pre and post, because there is fairly good data that show that certain tests, for example, performance-oriented mobility assessment, aka TINETI, tuck test, which is timed up and go, and BBS, the Berg balance scale. These tests were shown to be sensitive enough to capture the difference between the pre-TAP and post-TAP performance. So that's why we're fairly, with fair confidence, we're using these tests, at least for evaluation of the motor function. Now, cognition is not as clear. There is a study that showed that an MSC less than 21 could be a good predictor of non-response to shunt. And we're talking more to cognitive non-response to shunt. Again, needs validation. Some other studies, and I'll show actually one example, use the MoCA, the Montreal Cognitive Assessment Test, that evaluated, it seems like the change in MoCA could be a fairly good predictor of response to shunt. And we're not even talking about the degree, it's just if you capture the change. Now, these are just data from one of the recent studies that were published, and they were evaluating the scores and the differences between different tests, and specifically they were looking at a TINETI tuck test and MoCA test in the responders and non-responders. So responders, what they mean here, the responders, the VP shunt, and non-responders, the ones who did not. So when they evaluated the TINETI, for example, TINETI score, they saw that, so this is in between these groups. So that's for matter of this discussion, it's not what I wanted to concentrate on. But the pre and post TINETI score change had a statistical significance as opposed to non-responders. It did not have the even recorded change was not statistically significant. So it means, again, looking from another angle, the change in the TINETI could be a good indicator that the person will be responding to the test. And here is another thing, this MoCA test, what I was talking about. Again, in the responders, the change has is statistically significant, as opposed to non-responders. Seems that there is this, barely any change, and it was not statistically significant. So again, that argues, could you actually, use MoCA as one of the tests to implement to do before and after the TAP test or lumbar drainage, or whichever test is being used, in order to predict whether there's going to be a response to shunt or not. But I think more or less TINETI is becoming settled. The cognitive part is still ongoing. Now, as everything progresses, the evaluation of the prognostication to the response to shunt progresses as well. And the study, we're looking whether they can use the cerebral volumetric analysis in order to predict whether the people will be responding to shunt or not. And when you see these levels, level 1, 2, 3, 4, and 5 is just a different granularity level of the brain parts. As you see with each level, there are more and separate part regions that were analyzed in order to predict, to see whether they can reach the threshold where they can predict the response. And what it seems that the authors achieved a high diagnostic accuracy in discriminating CSF drainage responders from non-responders in a cohort of probable idiopathic normal pressure hydrocephalus patients. The volumetric analysis also showed promising performance in predicting the gait and cognitive outcomes after shunt placement. And again, I'm sorry, here it is. And it was at the granularity level of level 4, level 5. So they have to really look into, not like in it just like level 1 is like the whole hemisphere. And here there different colors means different brain regions that were analyzed. So level 4 granularity, level 5 granularity level demonstrate fairly good prediction for the response. And compared to the non-responders to CSF drainage, the responders manifested larger volumes of the inferior lateral ventricle, hippocampus, and several cortical gyri and frontal orbital lobes, but they had smaller procerebroidal white matter. I don't know whether it means, what does that mean? Does it mean that it was just squashed more and then, when the CSF was drained, it was, what that mechanical pressure was relieved? I'm not sure. And again, this is not like validated, but this is a good step forward trying, to really objectivize and, to see whether, you can, steer away from all these interventional things and try to identify the radiological markers or response. Again, is it going to completely change, the way we're doing? Probably not in the near future. Now, we also know that with normal pressure hydrocephalus, there is impaired CSF dynamic. And in the past, other tests were used, such as a radionuclide cisternograph in ICP monitoring, or then the lumbar infusion test, and they were measuring the compliance factor and looking for all these different waves. But again, none of them were able to confirm whether the patient will benefit from surgery or not. And some of them, especially like a lumbar infusion test, sounds fairly, could be fairly brutal. And that's why, really, I'm not aware that they were performed anywhere right now. It's a part of the evaluation of these patients with normal pressure hydrocephalus. Treatment. And actually, that's the only slide I want to treatment, because as I said, there is no, this is not the main reason for this talk, but the only definitive treatment is a shunt placement and CSF drainage. And that will be it. Let me stop sharing my screen. And we do have some time for questions. So.
We do. That was a great talk. Thank you very much. We have 3 questions that have come in so far, and let me get to those. How useful do you find the callosal angle measurement? In practice, this is very difficult to measure accurately as opposed to the Evans ratio.
I don't put a lot of weight in it. Let's put it that way. At this point, I'm also just exploring and trying to prove it to myself that it could be useful. So I do it, but I don't put much of the weight in it.
Okay. Oh, the next question was about presentation and notes being emailed, so we'll take that offline. Could you elaborate on the etiologies of NPH, particularly in a younger population?
Okay. So again, as I said, the NPH, there is the idiopathic NPH and there is the secondary NPH. The idiopathic as the name implies, we're not sure. But again, these are the older people would think, you know, it has to do with some fibrosis of the villi and granulations and diminished absorption of CSF in the superior sagittal sinus. Might be something to do also with the aging brain, with the loss of elasticity and all the other things that happen down the line. Now, the younger patients are usually more likely to be the secondary, and these are the people who have a history of the and it could be the fibrosis of these, for example, just a chronically elevated protein can cause also the fibrosis of the same structures, or it could be some subarachnoid fibrosis going on as well. But these are usually the people who have a history of subarachnoid hemorrhage, meningitis, head trauma, etc.
In NPH patients that have atypical AD or PD features, did the atypical features improve following the LP or VP shunt?
So if there is another disease concomitant going together with a normal pressure hydrocephalus, again, by placement of the shunt, you're really treating just normal pressure hydrocephalus component. Okay. So then the question, you know, becomes, okay, so if somebody has sort of this normal pressure hydrocephalus and they also suspect, or we confirm, you know, that they have Alzheimer's disease, it is sometimes really difficult to say which disease plays a bigger role in the clinical presentation. And really, I mean, when you think about it, there's probably no way. You can do the cognitive pre and post, testing and see. But again, another thing, and I'm sorry, I'm a little bit, I forgot to talk about the people who, you do the TAPS, and usually we do the genetic scores 4 hours after, or maybe a little bit later. Some people show the improvement 3 days later. Okay, not necessarily right away. So you do want to follow up with those patients, because they might say, oh my God, on day 2 or day 3, Dad started walking, and that could be possibly one thing, taking the mechanical pressure away, and another thing for increasing of the cerebral blood perfusion. So everything is restarting in the brain. So what was the question?
Did the atypical features of the Alzheimer's or Parkinson's improve after the shunt?
That really, as that study showed, that for the patients who have NPH and Parkinsonism, that the biggest benefit was, when you're also adding the dopamine supplementation. So, it's not going to cure the atypical Parkinsonism condition. So.
Sure. A question about NPH and obstetrics. We typically see 6 or so patients with NPH annually, and the obstetrician requests Noraxolanes for planned spontaneous vaginal delivery. The request always raises angst amongst the anesthesiologist. Personally, I will perform the epidural, but inject more slowly to avoid potential rapid rise in CSF pressure. Any pearls for the anesthesia department in this situation?
It's a very good question, and I don't think I have a very clear answer to that.
Nobody does.
It does, and I guess that's why everybody is, if it is truly, the normal pressure hydrocephalus, not the, if it is a hydrocephalus with increased pressure, so if it is an obstructive hydrocephalus, et cetera, you definitely need to involve the neurosurgical colleagues in the whole process. If it would be a truly normal pressure hydrocephalus, they're probably okay, going through that, because we're not dealing here with the shifts in the intracranial pressure per se, the rest, et cetera. So, but again, I would be a little bit worried, there are so many patients you were mentioning in the obstetrics with a normal pressure hydrocephalus. I question whether they actually have hydrocephalus, obstructive hydrocephalus, for other reasons, and that and then you really cannot say that it's normal pressure hydrocephalus.
Sure. Question: you had mentioned perfusion. Would things that potentially increase cerebral perfusion, like FNIR or things like that, play any role in patients where maybe the VP shunting isn't?
So we don't know that, because nobody looked into that, but probably not, because the perfusion changes are so secondary change to all the dynamics and the transmantle pressures and all of that, you have to take away, what caused it, rather than try to, artificially stimulate that. So.
And what is the role of endoscopic third ventriculostomy? I'm glad you spelled that out because I would not have known what ETV was, as an alternative to shunt in normal pressure hydrocephalus.
So that I probably would leave it, and as I said, there was a reason why I didn't talk about the treatment, because I don't want to misspeak, because we have so many excellent neurosurgeons who can give a separate even speech about the treatment of hydrocephalus, including normal pressure hydrocephalus, and I'm going to actually defer that to them.
And then last point/question. It seems the thing that we have best that has been continually most helpful with this diagnostic process is the long-term external shunt for a few days. And so not every place does that, and you want to go to places that have protocols. And do you have such a protocol in place? And if people wanted to refer patients for that, how would they go about doing it?
So, you mean for that external lumbar drain?
Mm-hmm.
Yeah. I'm actually more probably a proponent of the spinal tap things.
Okay.
The high level, the high volume spinal tap, because it's not only the actual drainage, but it's also the complication rate. And I have seen so many complications from those external drainage that it almost like well, it didn't justify you doing that. Again, some centers definitely do it because it has a high sensitivity, but 1 in 10 people will develop some sort of significant complication. And we find it actually, again, the sensitivity, 70 or even higher for the just a one large volume CSF tap. So that's a fairly good sensitivity.
Okay. I don't think any other questions have come in for now, and that was a great talk. Thank you so much. And we have our next grand rounds on the 29th, so keep your eye on your email to register for that.
Absolutely. Thank you very much. It was great. It was definitely my pleasure. So
bye-bye.